I have no disclosures except that no financial disclosures, but it's not really basic grayscale because I don't think you can do grayscale without using color. So there'll be a little color snuck in there, you'll see that. The other thing I tell my residents is that I don't think you can make a diagnosis in a vacuum. So the other disclosure is this is not just an atlas of bird watching and features of liver lesions. Really, I tailor my diagnosis based on the history as well. And so we will look at imaging features, but absolutely, whether it's a screening ultrasound in a patient at risk or it's an incidental finding when you're looking at a kidney for something else or the patient is symptomatic, that is going to tailor your diagnosis based on the imaging features. So I'm going to start a little bit with screening. I know Aya is going to talk about this as well, but it's important for us to remember that the patients who are screened, I'll give you a hint, this is going to be a Sam's question, are the patients with cirrhosis. So I'm seeing a lot of these folks coming through, and the screening patient is different from the patient who comes in with elevated LFTs, maybe has a fatty liver, et cetera. These patients actually have an underlying liver disease that puts them at risk for cancer, and so we are obligated to be thinking about, do they have a primary liver malignancy? These patients are currently screened every 6 months because that's been the most cost-effective way to find significant cancer. And basically any new lesion in these folks with cirrhosis has to be evaluated for potential HCC. It doesn't matter what the cause of the cirrhosis is, it's the cirrhosis that sets up the goal for the screening. So what do they look like? Well, any new lesion, non-specific ultrasound features, Stephanie's going to be talking about this. Basically, I need contrast to tell whether it's going to be an HCC. And I'm going to show you right now, here's one with an MR, which enhances, washes out, et cetera. That's an HCC in this patient. Here's another patient. Do I know whether this is HCC or not by ultrasound? I can't tell. It's heterogeneous. It may or may not be vascular. It needs contrast. In this case, it was a CT that was done. It enhances arterial phase, and it grows actually over a couple of months. You can see here in December, it's growing and it's enhancing. So we're going to hear about that from Aya later with LIRADS. What are the limitations? So I'm seeing several of these people a day, and where are the pitfalls? What do I need to watch out for? Well, the biggest thing I think of is we are limited at the dome and limited with lesions on the ribs. So I think my sonographers often don't scan up high enough, and they miss it. So does anybody see the lesion here? Okay. Isoechoic lesions, well, they're going to be hard. Diffuse infiltrating disease, that's hard. Anybody see a lesion? Not yet. Here's another one. Anybody see a lesion? Not yet. Here's the tips. Oh, there it is. 2 weeks later, there's the lesion. Okay, and it's vascular, and it's a little HCC. So make sure you get up there under the dome and make sure you pan out wide by the ribs. Here's another patient, a hep C cirrhosis, right upper quadrant pain. There's obviously a portal vein thrombosis that has an hepatic artery waveform in it. This is tumor. Where's the primary? Sometimes this is all you see. So here it is on CT. There's certainly an area here. I don't see the tumor here, but I do see it in the portal vein. The next category of patients, this patient has elevated liver function tests and didn't have a history of cirrhosis. And the initial ultrasound diagnosis on this was intrahepatic biliary duct dilatation. This was, of course, all these are done at an outside hospital, right? So at least you make the diagnosis of isolated biliary duct dilatation. That should make you think that something's wrong. Does this patient have sclerosing cholangitis, or is there a tumor? And if you look carefully at this, what's the lesion or what's the abnormality? There's a contour deformity here, right? And this is deep, but is it really just deep and not well penetrated, or is there really a lesion there? And so this patient actually, came in, and you can see there is actually a discrete lesion there when you set up your parameters well to look all the way through the liver. This was an intrahepatic cholangiocarcinoma, which is the second most common primary hepatic malignancy. And the reason I'm including it here is because these patients with cirrhosis, again, who we're seeing on our screening ultrasounds, are also at risk for cholangios, in addition to being at risk for HCCs. We know that ductal disease puts people at risk for cholangios as well as viral disease, but cirrhosis certainly should make you think it may not be an HCC, but if you see dilated ducts in somebody who's at risk, think about cholangio too. all right? These things are all on your handout, so I'm not going to read you the slides because we're running a little bit behind. So cholangiocarcinoma, how do you pick it up? The grayscale, again, variable. It may be invisible. Remember, it's a stricturing lesion, so you may not actually see much of a mass, okay? Isolated duct dilatation, that should make you think, is there a cholangio somewhere in there? So here's a nice case from the ARP. You can see the ducts are dilated, and when you look closely here, you can see vessel. Here's the duct, and there it is. It's basically isoechoic to the adjacent liver, but there is a little mass here in the duct. So I call it a stealth lesion. Here you can see on CT dilated ducts, and here is a little bit of the mass centrally. And when you look at the path, again, a stricturing lesion, sort of crawling along, sometimes crawling in the ducts as well. I didn't bring you more ductal pictures, but just remember if there's a mid-duct lesion that's a soft tissue mass, that's almost always cholangio as well. So now I'm going to move on from our high-risk patients into people who just show up at your doorstep without symptoms really, but they're sent in maybe for something else. Elevated LFTs, I'd call these incidentals, as well as somebody who's coming in for renal stones or maybe for gallbladder, okay? And here's somebody who has a big mass, about 4-centimeter mass in the liver, 44-year-old guy, incidental ultrasound finding. Can I tell what it is? Well, I can't. So this patient needs to go on to other imaging or needs contrast, right? So in this case, is it a primary HCC or a MET? I don't know. And is it benign? Well, the odds are it's going to be benign, right? The patient doesn't have any other symptoms, but you sort of have to prove it. So this patient in my practice will go on at this point to an MRI, and this is an obviously T2 bright lesion hemangioma. So these are our most common incidental benign hepatic lesions. They're considered a hamartoma, anywhere from 1 to 20%. Rarely are symptomatic. Occasionally they will enlarge during pregnancy and very, very, very rarely will bleed. Management, basically, this is another SAMS issue, and I'd be welcoming questions and comments on this as to what people do with them. And I will tell you it's variable in my practice. Some partners ask for a follow-up ultrasound on these, some people ask for an MR on these, and some people do nothing. So the literature, though, tells us that in a patient with no risk factors for malignancy, if you see a classic-looking hemangioma, and we'll go through the features, they do not require a follow-up. Some people do a single 3 to 6 month follow-up, okay? So what is classic? And about half of them turn out to be classic. And homogeneous, hyperechoic, and some posterior acoustic enhancement that you can see here. What are the other features that you've seen about the other half? Well, you can see a hyperechoic margin or an echogenic margin with a hypoechoic center, or sometimes these hypoechoic little nodules in it. You can see scalloped borders. It may not be nice and smooth. And as with our index case, it can be heterogeneous and even hypoechoic. And I will say that now that everybody seems to have a fatty liver, unfortunately, many of our hemangiomas have become hypoechoic. So ultrasound isn't as good as we used to be because our background has changed. The other thing about hemangiomas to remember, and I learned this from Bill Middleton, I found this really helpful, is it can be a variable appearance in a single patient. So this patient has a lesion here that's vascular, that's a little bit scary, hyperechoic over here. So this patient, because this was atypical, went on to an MR. This one, classic hemangioma, enhancing nicely. This one, same thing. So atypical appearance does need to be corroborated. We're using MR, but you can use ultrasound contrast as well. It can have a variable appearance in the same exam. And I looked around to find an example, and one came in last week, which was great. Here we are, 8 in the morning, hypoechoic, maybe through transmission, I don't know. Here we are, 8:20. Now it's getting hyperechoic, but a little bit hypoechoic in the center. Different position. This one's sagittal. This is transverse. Now I've got the through transmission. It's more hyperechoic. And I actually knew this was a hemangioma. The patient had had a prior MRI. So here it is, proven hemangioma, different appearance within the same exam, depending on positioning and just timing and blood flow. So what do I do with them? Well, when should I confirm them? If they have any atypical features, vascularity, even though this can be normal in hemangiomas, you still want to be sure it's not something else. Is there shadowing or risk factors for malignancy. So I'll show you some examples here. Here's a patient with Hep C who we were doing a screening for cirrhosis. And again, this looks fairly classic here, but it's a high-risk patient, so he goes on and he gets his MR. How about this patient, right upper quadrant pain? Is this a giant hemangioma? What's wrong with it? Through transmission? No. Shadowing. Vascularity? Yep, lots of it. Irregular margins. So large echogenic lobulated vascular attenuating needs confirmation. Here's the CT. This is not peripheral discontinuous interrupted globular enhancement. It's basically hypoattenuating. What else do you see? Free air and colon mass, obstructing mass. So this patient actually had a large colon cancer with a perforation. That's why he came in with right upper quadrant pain, giant echogenic mass on ultrasound. Okay? Here's another one, echogenic lesion. Is there through transmission or enhancement? No, there's shadowing. It's a little bit vascular. Need to see what it is. Here it is. It's got fat. AML, right? So these are uncommon, but you can see them. Usually you'll see renal lesions as well. How about this patient? Slightly echogenic, no through transmission, incidental, except that the patient has right upper quadrant pain, atypical hemangioma, needs confirmation. Here we are. It's not bright on T2. It does enhance. It does not wash out. Has a nice little central scar on Gatavist, and this is FNH, which is our second most common benign tumor. We are going to find a bunch of these. They are associated with vascular abnormalities and hemangiomas in about 20%. And I will show you the one feature. This was supposed to be how you can diagnose these on grayscale. They're often isoechoic. We see them by contour. Anybody have an idea of what might be useful to tell if it's an FNH? Something that Stephanie's going to talk about. The spoke wheel vascular pattern. And we can actually see this by turning on the color Doppler. So remember this for the SAMS questions. Okay. All right. Third lesion. Right upper quadrant pain. Notice we're moving now into the people who have symptoms. It's indeterminate by ultrasound. Avascular, needs confirmation. What do we see on a CT? Hyperattenuating, no contrast has been given, doesn't enhance. That means that this is blood, right? So when you're thinking of bleeding lesions, not thinking about hemangiomas, really not thinking about FNH, you're thinking about adenomas. And these are our third most common benign lesions, but they are relatively rare. And they are at risk for hemorrhage if they're big. Usually the patients, we try to get them off whatever drug or enabling feature is making them grow, and sometimes they shrink on their own. Other things that can bleed, this is another adenoma. This patient is pregnant, right upper quadrant pain. You can see a lot of hemorrhage here, subcapsular hemorrhage, and this is a lesion. When you see it on MRI, it has obvious hemorrhage within it. So another adenoma. So I'm going to move now into symptomatic solid lesions, and then we'll move into the cysts and the avascular lesions. So we talked about bleeding. The other thing, the most common thing that I see that's symptomatic is actually metastasis. And how do I figure out that these are METs? Because their imaging appearance is quite variable. I look for history. I look for nodal disease in the adjacent images. If I can see a primary somewhere else in the abdomen, okay? So the appearance, we all know, can be hyperechoic, hypoechoic. These are targetoid ones. This patient happens to have a partially necrotic one from an endocrine. This part of this patient has a hypoechoic lesion. Here's a patient with some nodal disease, and this was not very evident on CT because we didn't have contrast. We do need contrast to see more conspicuity of these liver lesions, nicely seen as hypoechoic lesions by ultrasound. Here's another lesion, calcified lesions you can see here on ultrasound as well as on CT, and for those you think about a mucinous lesion like colon cancer. I want to spend a little time on the difficult metastases. So it's easy when you have a discrete lesion, you know you got to characterize it, right? What about the ones that we can't see? Well, does anybody see the lesions here? Stephanie, of course, does. So look for architectural distortion. Look for the portal triads. If you don't see the portal triads, that might be your clue. All bets are off in the cirrhotics because they don't have portal triads either, but in your regular patients, they should. So infiltrative architectural distortion as well as contour abnormality, loss of the portal triads. So I'm just going to show you a bunch of examples. Here's the lesion back here by the IVC. Here it is easily seen once you've got contrast on board in CT. Here's another one. See the lesions? Hard to see. You can see some little vessels, but we should see more portal triads, right? Here it is on MR, innumerable metastases, and they're small and they're bright on the MR, okay? So they're in here as well. Here's another one. This patient had polycystic liver and kidney disease, transplant patient. See the lesions? Really hard because the cysts give you some through transmission. Give you another image. Start looking back here. Again, there should be portal triads here. They're not here. Here is the MR, here are the cysts, and again, innumerable lesions. This was a metastatic Merkel cell carcinoma, just enormous number of mets interspersed, and these cysts made it very difficult. Brief mention, I think you probably will all recognize this. A young patient, vague abdominal pain, symptomatic, has a mass with a central calcification. Anybody? Fibrolamellar carcinoma. Okay, you got it. And it's a subtype of HCC. We can see the central scar on all modalities, but just for ultrasound, look for the calcium in the center because we can see that quite well. Let's move on to cysts and complex cystic masses, and again, I'm going to divide it into the symptomatic and the asymptomatic. Asymptomatic simple cysts, nobody needs review. Just remember, even thin septations are probably okay. Don't worry too much about them. Polycystic liver disease, same thing. We'll talk about these at the end if we have time. Symptomatic, though, liver abscess is the big problem for us, and for me it's a differential. Is it a liver abscess that I'm dealing with, or is it a necrotic met? And that comes up sometimes in your clinical settings. And so here it's really the history. Is there pain, fever, malaise, etc.? Half of them don't have a source, and only about half of them will have through transmission. But I do look for the grayscale findings, if you will. Through transmission behind something means to me that it is not solid, it is fluid, even if it's got a bunch of junk in it. So if I see a lot of through transmission behind it and I don't see any vascularity or it's just all around the edge, I think about, could it be an abscess? If you see gas, that's very helpful. But they aren't that common to find gas. Gas is in a very small minority. This is a problem because you have some central liver tissue that's okay, and then these cystic spaces around it, which are the areas basically that are coalescing little abscesses, the sort of classic rosette appearance you might see on CT or MRI. So solid appearance, acoustic enhancement. I'll turn on the color and hopefully get a little bit better flow than this. If it's avascular, I would be thinking about an abscess. Some of these, this person went on to MR, I'm not sure why, and you can see the halo of edema sort of around this and a fluid and debris level within it. Thick rimmed cavity through transmission, avascular, is it an abscess or a tumor? And I can't tell. I need the clinical symptoms, and these people really do need to be sampled because unless you know that they're febrile and septic and so forth, you're going to be talking about this as this could be a tumor. As it turned out, this patient did have acute cholecystitis, and this was an adjacent liver abscess, but it needed further verification. All right, this is an Aunt Minnie for you guys, probably. Cyst with daughter cysts, and another cyst behind it. Looks the same on ultrasound as it does on any other imaging modality, and a kinococcal cyst, right? So we know that these can be drained percutaneously and sclerosed, and we're just going to look for the imaging pattern. How about this one? These are more cysts. Polycystic liver, excellent. Usually seen with polycystic kidneys as well, and here are the kidneys for you. These do not require anything. These do not actually lead to liver failure in most cases. How about this one? What's wrong with this for just a polycystic liver disease? Well, look at the margins. These are not tiny, tiny, thin-walled cysts. These have thick walls. So once you see thick walls, is it infection or is it tumor? And even if you don't see vascularity, think about tumor. This was metastatic carcinoid. And the last thing is a cyst look-alike. This patient had an SBO, has aplastic anemia. These look like they could be cysts, but they really don't have a wall. And they do have a little bit of vascularity in them, some of them. And they don't have a rim, as I said. So cyst look-alike, Always turn on the color. Lymphoma, right? So hypoechoic, very, very uniform. They do transmit sound. They can create masses. They are aggressive, and they can be nearly anechoic. So think about that as well. I think for the instance of time, I'll skip this or just mention that there are a couple of cystic tumors. I wasn't sure how much biliary stuff to put in here. These have been renamed. They used to be cystadenomas. They are now called intraductal papillary neoplasms of the bile duct. And they have septations, which can enhance. If they are simple, thin septations, don't worry about them. But once they start forming thicker septations, nodular septations, then you have to think about malignancy. So mural nodules are rare in the mucinous cystic neoplasm. This used to be your papillary cystadenoma, okay? Once they have intraductal papillary neoplasm with this cauliflower-like appendage in it, sticking in with vascularity, with enhancement, think about this could be malignant, and the more solid components you have, the more likely it is to be malignant. Here's another one with a big, big mass in it, enhancing, as you can see, and this comes out. Looks as you would expect it to. And this was, again, intraductal papillary neoplasm. These are sort of like the IPMNs in the pancreas. That's how I remember them. They can be relatively benign. Once they start getting solid, growing, enhancing components, malignant need to come out. All right, so in conclusion, we are the first imaging for liver lesions. I think if we want to make a diagnosis and not just give a differential, we need the indication and the history to be able to narrow things down. The significant imaging features for me are still echogenicity. Remember, you're dealing against a background liver, and hopefully that's normal. The flow is important, and then architectural distortion and margins. Thank you so much. It's been a pleasure.